Hello everyone, I'm Donald Manlapas and I'll be your facilitator and your lecturer for your physical therapy examination of the upper extremity orthopedic conditions. Particularly, these are musculoskeletal conditions. So the objective of this session is actually to help you navigate and review part of your anatomy and kinesiology, as well as your background in medical surgical foundations. And then we'll apply those things in the examination of the upper extremity, particularly in the shoulder, elbow, wrist, and hand. And of course, towards the end, we'll help you and teach you how to document and do history taking for this kind of conditions or patients. But before we start, we need to go back to the different definition of terms. When we talk about now tendinitis, we're talking about now inflammation of the tendon. The word itis there means inflammation. So tendinitis, it's inflammation of the tendon. The next term is tendinosis. So tendinosis, from the word osis, osis means degeneration. So this is actually a degeneration of the tendon. When we talk about now tenosynovitis, from the word synovium, synovitis, and itis, so it's the inflammation of the synovium. Okay, particularly once the tendon now attaches to a specific structure. So a common condition that is related to tenosynovitis is actually your Decker vein. In French, it's Ducova. So Decker vein syndrome. So Decker vein syndrome is actually known as your stenosing tenosynovitis. Okay. Again, Decker vein is stenosing tenosynovitis. But when you talk about now tenovaginitis, okay, this is commonly referred to trigger finger. Okay, when you talk about trigger finger, we call this one stenosing tenovaginitis. Okay, so again, synovitis is more related to your Decker vein, while your tenovaginitis is more commonly related to your trigger finger. Okay. You heard of Decker vein syndrome, and usually these are the affectation of the tendons near in your anatomic snuff box, right? While your tenovaginitis, trigger finger, the most commonly affected finger is the third and the fourth finger. Again, it's the third and the fourth finger which is affected in your trigger finger. So I know some of you will heard that trigger finger is the one that when you hold something and then most of the patient will complain that they drop an object. Okay, why? Because there's a lacking. So there's actually because like trigger finger from the word trigger, so there's actually lacking of some of the digits in the fingers. Wherein the most common is the third and fourth finger. Now, let's go now with the tendinitis in the shoulder. Okay, in the shoulder complex, very important. You need to review your background in anatomy and kinesiology. Why? Because sometimes this will explain how your assessment will actually go. How will you zero in that? For example, you have a patient, and the patient will have now shoulder pain pointing on a different area. You should zero in what specific condition by doing some maneuver, by doing some palpatory procedure, and at the same time doing some sensory assessment if needed. So first we have your supraspinatus tendinitis, which is actually most common in the clinic. Most of the referral of the rehab doctors will tell, oh, please treat this patient with supraspinatus tendinitis. Origin can be acute calcific tendinitis or can be a chronic degenerative tendinitis. Usually, when you have your supraspinatus tendinitis, patient will actually complain, okay? Will complain now more of a lateral pain, okay? Posterolateral pain in the shoulder, okay? Why? Because of the attachment of supraspinatus from the origin in your suprascapular fossa going now to your greater tubercle. So what happens is that when you have your supraspinatus, the leverage or the length of the tendon is actually very long. Okay, wherein if you read some of the journals, wherein there's an area in your supraspinatus that is least vascularized, and that specific area is more commonly damaged. Okay, So right now, I know you're thinking, oh, supraspinatus tendinitis. There's a special test for that, and we'll learn that soon. Okay, we'll learn that later. So the next one is bicipital tendinitis, also common in the clinic. Most specifically, the patient will complain now pain upon flexion and extension of the shoulder. Okay. Sometimes, of course, if you flex also the elbow from the word bicipital tendinitis, remember that the long head of biceps passes now between the tubercle, the lesser and greater tubercle, via your bicipital groove or floor. Okay, so what will happen is that there's an irritation on that specific area. Okay, there's also, if you go back to your medical surgical foundation, is also depend on the bone configuration. So, for example, the floor of the bicipital groove is actually shallow, or it can be actually very protrude forward. So what happens is that the tendon has a tendency to have a friction, okay? Friction on this. But of course, it is actually protected by a different structures. But because of repetitive use, it becomes inflamed or become inflamed. So that's your tendinitis. Okay, most commonly supraspinatus and bicipital tendinitis. When we talk about now impingement syndrome is actually called the painful arc syndrome. When we talk about now syndrome, it's actually collections of symptoms, right? So it's a big umbrella, okay? And most commonly, when we have now impingement, it can be two types. It can be primary and secondary. When we talk about primary, it is the structure itself that is affected in any term in medical conditions. When we talk about primary, the main problem is this main structure itself. Like, for example, primary Parkinsonism, the problem is really the basal ganglia. The problem here in the primary impingement is actually maybe the shape, okay, of or the configuration of the bone. While secondary, when talk about secondary impingement, it means that there's affectation in the nearby area. For example, you have an inflamed bursa. Okay, for example, your subdeltoid bursa is impaired. So, if it is inflamed, what will happen? There will be congestion in the shoulder area, right? There's a congestion in that specific area, and that's causing now impingement of the different structure. But the most commonly related condition with impingement syndrome is your rotator cuff syndrome. Okay, remember your rotator cuff muscles, right? Your seat muscle, your supraspinatus, infraspinatus, your teres minor. Okay, those are the three main components. And there's a physical shearing and compression on the rotator cuff tendon between a closed space rigid coracoacromial arc and the humeral head. So we give a stages for rotator cuff disease by using the near stage of impingement, particularly for the rotator cuff. Stage 1 is just an edema and an hemorrhage. Stage 2, there's actually fibrosis and tendonitis. Okay? And then after that, stage 3, there might be a partial rupture or full thickness tear. Okay? So, or tendon degeneration. Okay? If it's less than 1 cm, then it's 3A. If it's greater than 1 cm, it's 3B. And of course, the final stage will be multiple tendon tear. So mostly in the clinic, you'll have your stage 2 and stage 3. Okay, you'll have this patient because stage 1 usually the doctor will give some during the acute stage like painkillers, and then the doctors will give some advice for protection of the joint. But throughout the rehabilitation, during maybe acute and subacute stage, we might get in by using our modalities. But stage 2 and stage 3, we give some therapeutic interventions for them. Now, so what are the common? Let's talk about now the primary one because of the configuration of the bone. So type 1 is flat, okay? So the acromion can be flat, it can be curved, and it can be hooked. The most common, which is normal, is usually curved. But those with hook type or type 3 are the most predisposed with impingement syndrome of the shoulder. Again, the most common type is type 2, that's normal. And then the one will have impingement is actually the hook type. So if you look at here, the hook type, for sure there will be impingement in this area because of the different structure that passes by in this region, particularly your supraspinatus, sometimes your infraspinatus. Another common condition, adhesive capsulitis, or what we call your frozen shoulder. I know you're very familiar with adhesive capsulitis. Sometimes it is actually called your pericapsulitis or diabetic pericapsulitis. So, what is a capsule? Okay, if we go back to your anatomy, capsule is, imagine a masking tape. Okay, for example, this is the head of the head of the humerus. So the capsule is actually enveloped in this area, the edge of that specific head. Okay, of course, it gives stability. It protects also the shoulder joint for any stress. Okay, but what happened with this kind of patient with adhesive capsulitis? They try to remain their shoulder in a protective position. Okay, why? Maybe because there's an ongoing inflammation on the different structure. Like for example, there might be rheumatoid arthritis in the shoulder. Okay? Why? Why I need to tell that? Because the most common predisposing factor for adhesive capsulitis is immobility. If the shoulder joint is immobilized for a long time, okay, nagkakaroon ng tinatawag na adhesive, okay? Kaya nga it's called adhesive capsulitis. Adhesive capsulitis in the shoulder can be caused by, for example, as I mentioned, pain. So the most common is predisposing factor is immobility. Okay? Guys, so immobility, what else? Some will have now the personality, okay, personality type. Some will have some hormonal problems, okay? And if the patient is diabetic, for example, that's the reason why it's called diabetic pericapsulitis. These are the predisposing factors. Why there's a predisposing factors? Because adhesive capsulitis is actually a disease or condition which is actually idiopathic in origin. Sir, what's the meaning of idiopathic in origin? Well, when we say that a condition is idiopathic in origin, when we talk about now idiopathic conditions, there are three things that you need to take note. One, or first, the etiology is unknown. Okay, again, if it's idiopathic, one, the etiology is unknown. Second, okay, there's a gender bias or gender predilection. When I talk about gender predilection in a condition, like for example, adhesive capsulitis, it is more common in female than male. Okay? There's a gender predilection. The third one, it is self-limiting, meaning it actually resolved by itself. Okay, particularly for adhesive capsulitis, most of the references will tell us sometimes as early as a year or 6 months, there's an improvement already, and most probably after 2 years resolved if properly care, if there's a proper care and proper rehabilitation. Okay, again, when you talk about now idiopathic conditions, there are three things that you need to take note. Number one, it should be unknown cause, okay, unknown etiology. Okay, so there's a unknown cause, but there's a predisposing factors. Okay. Number two, there's a gender bias or gender predilection, and number three, it should be self-limiting. I'll give you another example. Idiopathic scoliosis. Remember scoliosis, right? Scoliosis commonly seen in females. Okay, that's your scoliosis. Okay, so unknown cause. There's a lot of cause for scoliosis. Maybe caused by muscle imbalance, caused by some skeletal problems and diseases or conditions, and sometimes self-limiting. There will be an end of that specific condition. So self-limiting also for your for that specific condition, scoliosis. So again, if you read the word idiopathic, it means the three things. Okay. In your adhesive capsulitis, there's a stages or for or like improvements of the condition or maybe a progression of the condition. So there's a freezing, frozen, and towing stage. In freezing stage, of course, um, usually medication is given, but we go with the second stage with wherein there's a frozen shoulder, where we do like stretching, we'll do our sum of maneuvers to improve the mobility of the shoulder. And the towing stage is actually there's still some of limitation of motion, but there's no pain already. So that's your adhesive capsulitis. Next, also most common, shoulder dislocation. So the mechanism usually is shoulder abduction and external rotation. Okay, so the mechanism, the movement of the shoulder is a sudden abduction and external rotation. And usually in the shoulder will have anterior dislocation. Okay, so the chief importance you need to take note is actually the anterior labral tear. So because of the anterior dislocation, there's a tear in the labrum. Okay, there are different procedures done for shoulder complex with dislocation. Particularly, we have your Bankart, Bennett, Putiplat, Hillsack, and Cockers rather. So I think you need to review and check on the definition of this one, particularly Bankart, Bennett, Putiplat, Hillsack, and your Cockers maneuver, or it's actually a relocation type. So reference that is good to check on this one or your medical surgical background. So your notes coming from Dr. Byron Angeles. At the same time, Bankart, Bennett, Putiplat, you can also read this one in your therapeutic exercises. There's a good definition of this kind of procedures. So that's the most common conditions that we can find in your shoulder. How about in the elbow? In the elbow, it's more on the sprain and strains. And usually when you talk about elbow, the first condition that came to your mind will be your lateral epicondylitis, right? Your lateral elbow or your elbow epicondylitis, whether lateral or medial. So when you talk about strain, going back to the basic definition, muscle strain, okay, is a problem now in your muscle group, while your strain it's more on, or your sprain is your ligaments, while your strain is muscle. Okay, so we have your collateral olecranon bursitis. So olecranon bursitis, particularly your elbow bursitis or your student elbow, okay, is also common condition. Okay, there's a different terms used, like for example for your student elbow or your olecranon bursitis. So you have your Draftman's elbow. It's also called as your Draftman's elbow. It's if it's based from occupation, because remember your draftsman, right? They have the table and they write, and then they put now the elbow. Similar with students, they're thinking, they're studying, and I hope you are studying. Okay, so that's your olecranon bursitis. Okay, common also in the elbow. But what is more common here is actually your lateral and your medial epicondylitis. And between the two, lateral epicondylitis, of course, is 7 times more common than your medial epicondylitis. Okay? Your lateral epicondylitis is actually your, also known as your tennis elbow, where your medial epicondylitis is your golfers, pitchers, little leagues elbows. Okay? Little leaguers elbow, or, rather. So, what are the different muscles that you need to check? Okay? So for medial epicondylitis, the pronator teres is mostly affected, and for your lateral epicondylitis is your extensor. So that should be ECRB. Sorry for that, for the typo. Extensor carpi radialis brevis. So your ECRB, again, your ECRB is the most commonly affected. Okay, followed by your ECRL, your extensor carpi radialis longus, and your extensor digitorum. Again, it should be ECRB. Okay, the most common is your ECRB. Now, another one, common in kids, we have your pulled elbow or nurse's maid elbow. So this one, you need to take note the position, okay? Particularly if the elbow is extended and the forearm is pronated, okay? And there's a sudden pull, okay? If you look at Norkin and some of the books, there's a mother or maybe a nanny holding on the kid, okay, and the kid's position, or the kid position, the elbow position is actually extended and pronated, okay, and there's a sudden pull. So what happened is that there's a damage of a specific ligament called annular ligament. Actually, the annular ligament actually surrounds that specific joint, and what will happen is that the elbow is pulled because of the sudden force. Okay. When you do now your assessment of the elbow, all movements are normal except supination. Meaning, you will see that movements of your pronation or your range of motion of your elbow flexion rather, extension is normal except for supination. Okay, so supination might be decrease in active range of motion as well as your passive range of motion. So that's your pulled elbow or what we call nurse's maid elbow. Now, so very easy, a few conditions in the elbow, but there's also a lot in your wrist and hand. Particularly, we have your affectation of the tendons and the tendon sheath. We have your tendon lacerations. We'll talk about different ruptures, okay? Particularly the rupture of the extensor pollicis longus, the rupture of central extensor slip, your boutonniere or buttonhole deformity, and the avulsion of the flexor profundus tendon, okay? What else? We have your mallet finger, also common, mallet finger. Rupture of the ulnar collateral ligament, okay? And the one that I'm explaining a while ago, we have your stenosing tenosynovitis, or what we call Decker veins disease, okay? It is the affectation of your near your anatomic snap box. We have your Apollo ex pobre, your abductor pollicis longus, and your extensor pollicis brevis, right? So usually it's bilateral and common in females. While your trigger finger, the most common, as I mentioned, the third and fourth finger, your trigger finger or your stenosing tenovaginitis. Again, this is also common in female around 40 years old. Okay, so these are the most common conditions found in your wrist. Okay, particularly in your thumb area. Also, you need to check for in your ocular inspection different types of contractures and deformities. Particularly, you have your intrinsic plus, okay, your extrinsic plus, swan neck deformity, boutonniere deformity, your claw hand deformity, and of course, you have your Dupuytren's contractures. Okay, so I think this will be covered by your medical surgical background. And some peripheral nerve problems, we have your carpal tunnel. I think most of us know the condition about carpal tunnel syndrome, wherein the median nerve there's a median nerve affectation. And we have your pronator teres syndrome. Okay? Now, so that's the medical surgical background, giving you some common conditions found in the upper extremity. Now, let's talk about now subjective examination. So how will you do your interview? What are the things that you are looking for your patients? Okay? First, you need to check, of course, the initials of the patient when you write it, the name of the patient. So, for example, hi, I'm Donald. I'll be your physical therapist for today. How may I call you? Can you have your complete name? Okay? Sometimes the age, the name of the patient, medical history, can be actually retrieved from the medical chart. So when you open the chart, so for example, in the hospital, you have the doctor's notes, nurse, and then you have the PT notes, or who else were writing their a part of the medical allied field. So they are writing most of the notes. So that's very important. As mentioned in the previous lecture, there's a legal implication when you write something, right? So that's a legal document, okay? So you need to be precise and very accurate on the things that you're writing there. So we have now, you can ask, of course, for the handedness and gender. You can also retrieve it from the medical chart. So what are the things that you need to check, okay, or ask for the patient? Pain, okay? When you talk about pain, okay, you need to describe and quantify the pain. Like, for example, can you please, so sabi ng pasyente, ask the patient to pinpoint, okay, dito yung masakit. So you note for the location, okay? Masakit daw dito, okay? And then you ask the patient to describe the pain. Paki-describe nga po yung nararamdaman yung pong pain. Okay? And then after that, you need to grade the pain. We're in 0, no pain. Using maybe you can use a visual analog scale or maybe subjective pain scale. For subjective pain scale, you can ask the patient 0, no pain, 10, worst possible pain. Is there a feeling of locking, feeling of instability? If the patient said yes, then it might be a possible or probable dislocation of the shoulder. Lalo na pag gina-guard niya, masakit na masakit. There's a pain in every movement. Baka merong fracture. Okay? Weakness, heaviness or yung shoulder parang nangangalay, parang mabigat. Okay? Numbness, paresthesia, or tingling sensation, and then you can ask that. Combination of the proximal and distal symptoms, like masakit daw yung dito niya, and at the same time, meron din daw masakit in this area, in the forearm area. You might need to check for a double crush syndrome, okay, in the upper extremity. Remember, this is one kinematic chain, okay? So affectation in some parts in this area might have some damage in other remote areas or particular areas or distal areas. And then we have your functional limitation. So functional limitation, you may ask the patient, ano po yung hindi nila nagagawa, ano yung mga inability nila. Okay? Let's go now with the pain assessment. As I mentioned to you, you need to quantify. Okay? It can be subjective pain scale, the one I mentioned to you. 0, no pain. 10, worst possible pain. Saan po dun? Okay? Visual analog scale. There's a 10-meter scale sa paper, and then the patient will just mark kung saan, and then the therapist will measure. For example, he marked that specific line around 3.5. Okay, so that's the visual analog scale. And then there's also a body diagram pain chart. And one of the most common outcome tools that used for pain assessment is the McGill Pain Questionnaire. And then you can also, if available in the clinic, you can use your pressure threshold meter, or what we call your dolorimeter or algometer. So I think in the PT lab we have our algometer there. Okay, so the pressure threshold meter. So it's not just the pain, but also the pressure on that specific area. If you later on palpate on the specific region, you qualify duration. So, intermittent, continuous, onset of pain, sudden or insidious, location, localized, diffuse, radiating, the type will be dull, aching, or shooting. So, you need to note this one. So, it will take a practice when you do this one. So, duration, gaano po katagal yung nararamdaman yung pain? Sabi niya, 7/10, 7/10. How about the onset of the pain? Is sudden, insidious. Insidious means gradually increasing. And then location, localized, can be diffuse. Usually, if you have a localized, then you can zero in that the condition or the problem is in that area. If it's radiating, maybe it's a sign that maybe there's a nerve damage. And then dull, aching, shooting, the type of pain. So these are the complaint of the patient, and then its counterpart structure that might be possibly or possible affectation. So sharp shooting is a nerve root pain. If the patient now mentioned sharp, bright, lightning-like, it's a nerve pain. While burning and pressure-like, it's more on sympathetic nerve pain. Okay, but most common are this last four. So mostly pag merong tingling, pag merong lightning-like, there's a nerve affectation, peripheral nervous affectation. But if it's boring, then it's a bone affectation. If there would be pain that cannot be actually dismissed, or pain that will not be relieved upon movement, even at rest, then it might be fracture. Okay, sharp, severe, intolerable. But if you heard the word cramping, then it's a muscle. Okay, throbbing, it's more on the vascular. Okay, why? Because there's also a condition known as what we call thoracic outlet syndrome. And in thoracic outlet syndrome, there's an affectation of vascular component in the shoulder region, and of course the nerve affectation. So there's what we call thoracic outlet syndrome. So more or less, it's more on the vascular affectation. Okay. So for the history of present illness, you may ask the patient, when and how did it start? How long has the problem been present? So, nung kailan pa ba nangyari yan? Okay, yung sakit nyo sa shoulder nyo or sa elbow nyo. Okay? The mode of onset, you can ask. Okay? Mechanism of injury, particularly Fuchs, for a fall on an outstretched hand. So, nahulog siya. Maybe magkaroon ng tinatawag na Cole's fracture, or what we call Smith's fracture. So, maybe may fracture sa wrist, pwede may fracture sa shoulder, or pwedeng umabot hanggang shoulder region, particularly the clavicle. Okay? So if there will be Fuchs, ang iniisip ko kagad, pagdating dito sa area, sa proximal area, might be a problem with a fracture in the clavicle. Okay? So, activities altered or increased. So, nabawasan ba? So, ano yung mga pinagawa sa kanya? Na ginagawa niya mga activities na hindi niya ginagawa ngayon. Pertinent events related to injury. Okay? Is that injury happened during a practice or during a competitive play? Okay? The course of symptoms, usually acute, is 48 to 72 hours. Greater than 2 weeks, it's subacute. And when talk about chronic, it's around 2 to 6 months. So that's the course of the symptoms. Next, you also you ask some medical consultation and then ancillary procedure done. If there's an X-ray, if ever there will be check for the nerve, if there's a tingling sensation, particularly your NCV, okay, nerve conduction velocity, checking your nerve conduction velocity. Prescribed medication is very important. So again, before you do any subjective history taking, as I mentioned, what we mentioned always to you, you need to check the vital signs of the patient. Maybe the patient is taking some hypertensive drugs and some drugs that might affect musculoskeletal problems. Like for example, if the patient is taking, of course, not really common, but sometimes they inject some steroids, and steroids might cause laxity on the ligaments. Okay. Management provided if there's a previous physical therapy, referral to rehabilitation. Okay, that's your HPI. So HPI is the history of present illness, all related with the condition. But when you talk about past medical history, okay, others, okay, like previous injury in the same area or other areas, treatment or medication given or recovery, as I mentioned to you, steroids if they're getting, analgesic like the day of the treatment, no symptoms or false negative. So baka naman naka painkiller siya, kaya when you're examining the shoulder, there's no pain. Okay, that this might affect with your assessment, right? So if there's analgesic, particularly during the day of the treatment, you cannot really assess or validate all the signs and symptoms because of this drug effect. Okay. Take note of your family history and some previous PT sessions. You can note that under also your past medical history. Home situation, we have your family support. Okay, you might to check the home environment or ask the home environment of the patient. Okay, pertinent house furniture of appliances. Baka yung patient mostly dealing with overhead cabinets. Okay, overhead cabinets. So overhead cabinets will have some problem with the shoulder. Okay, how about the lifestyle, occupation of the patient, the type of work. Okay, usual position, the ergonomics, okay, and the working environment, okay. Hobbies, recreational activity, sports. So tennis, pag tennis, baka tennis elbow mostly more common. For those who are playing badminton, okay, for those who are playing basketball, so any sports related activities, volleyball, so pwede siya shoulder, upper extremity. Knowledge on stretching and protective equipment. So, baka during play ba, nag-stretch ba siya before and after? Is the patient having this protective equipment? Like, for example, a band. Like, for example, sa mga tennis player, meron silang armband or forearm band. And, of course, if the patient is a smoker or drinker, you need to check on this one. And of course, lastly is the patient goals. You want to eliminate, usually, of course, you want to eliminate the pain, and the patient now goes back to previous work or their previous sports, or go back to sports again, particularly if it's an athlete. Now, some of the patient will also complain this type of chronic diseases, like for example, rheumatoid arthritis and osteoarthritis. And we will discuss that in our assessment. Okay, so let's go now to the O part. Okay, how do we do an examination? So first, we need to do the vital signs. Okay, in writing, vital signs is under objective, but in our procedure, we'll have ask the patient some preliminary questions. We do the vital signs, and we do now the history taking, and the last part is objective examination. Again, basic information like name, I'm Donald, okay? I'll take your vital signs now before we proceed with the subjective history taking. And then after your subjective history taking, you're the complaint of the patient, the demographics, the complaint of their patient, the history of present illness, past medical history, the lifestyle, home situation, environmental situation, and then, of course, you're the patient goal. Then, after that, you'll do now your objective examination. So, in the O part, we'll start with ocular inspection. So, once the patient comes in now in the clinic, you need to check if the patient is guarding on a specific aspect of the hand. Okay? So, manner of arrival, if it's protective guard on the arm, mental status, the body type, ectomorph, mesomorph, endomorph. Okay? Ectomorph, medyo payat. Mesomorph, muscular. Endomorph, medyo malaki. Okay? If there's an attachment, nakasling ba yung pasyente? Okay? Or baka merong mga orthopedic appliances na attachments sa kanila after, for example, a surgery. Or maybe there's actually the patient had a fracture and kailangan i-protect yung area. Okay? Adaptive devices, slings, splints, forearm bands, orthotics, yeah, kung meron siya. So, the following should be observed from head to foot observation, okay? So, again, head to foot in the writing, okay? Pero pag nag-assess tayo ng postural, okay? Postural, pababa, pataas, okay? But this one is ocular, so titignan mo muna. So, change in color, like for example, pag merong cyanosis, baka maybe there's a decrease in blood supply. Redness and erythema, okay? You need to check on that. There might be an ongoing inflammation. Change in the texture of the skin, okay? Tingnan nyo, okay? Lalo na pag matanda, you know naman to quantify, or mas bata, pero iba na yung structure or the texture of the skin. You need to check on that. Dry and scaly means decrease in sympathetic activity. While if you see like the hand, the forearm a bit smooth, shiny, and glossy, there might be increase in sympathetic aspect or component. So there might be nervous system, okay, affectation that specific area. Swelling, okay, can be localized, can be generalized, okay. Take note that swelling is documented under OI, while edema is actually documented in the palpation. And I'll explain later paano yun. Again, swelling, so upon ocular inspection, there's a swelling. Okay? It can be localized, it can be generalized. Scars and wounds, you check on that because later on, if you might apply some modalities, you need to check on the scars, the wounds. Bruising or hematoma in the specific area, you need to check on that. Deformities. So we have your shoulder height. So usually the right hand, if the right hand is the dominant hand, the dominant side, then it should be lower than the left one. We have Sprengel's deformity. Sprengel's deformity is an affectation in the scapula, right? So one scapula is higher compared to the other one. We have your alteration of the bone shape. So baka meron naka-depress or meron naka-protrude. There may be fracture. And even AC deformity or what we call step deformity. When you assess the patient, there's a specific depression. Okay? There's a depression. So parang nakaseparate siya. Okay? There might be step deformity or a positive step deformity, usually seen in AC joint. Okay? Winging of the scapula. Okay? So winging of the scapula can be a problem with your cranial nerve. So you need to go back again. So it will be can be a medial winging, or maybe a lateral winging. Okay, so when we talk about now the winging of the scapula, you might need to check the different muscles, particularly the serratus anterior, or can be the rhomboids muscle. So you need to check on this one. Muscle wasting or atrophy, particularly in the deltoid area. Okay, why? Because if there's a muscle wasting on the deltoid area, there might be a problem with your nerve supply for that specific muscle, particularly your axillary nerve. So your axillary nerve is commonly damaged if there's a dislocation or even if you have a fracture as well. So again, you can be a problem with your axillary nerve if there's a wasting of your deltoids. And then of course, you need to check if there's an amputation in the shoulder, in the upper extremity. In the elbow, you need to check if there's a carrying angle or what we call cubitovarus or cubitovalgus. Okay. In the hand, so you need to check if there's some nodules. So sabi ko sa inyo kanina, if you have a patient with osteoarthritis, sometimes they have Heber-Dens and Bouchard nodes. Heber-Dens is seen in the distal aspect or DIP, distal interphalangeal joint, while your Bouchard is seen in PIP. Again, Heber-Dens is seen in your DIP, while your Bouchard's is seen in your PIP. Okay? Some patients will have, like for example, in patients with rheumatoid arthritis of the hand, they will have ulnar drift. Therefore, in your assessment, in your subjective history, you might want to ask kung anong ginagamit niya, paano siya pag kumakain, the spoon, paano siya maghawak ng baso. Is there a difficulty in eating, in doing self-care? Okay? Because they need to do some manipulation by using their hands. Okay? Some will have Dupuytren's contracture. When you talk about Dupuytren's contracture, it is actually a palmar fascia thickening. Again, Dupuytren's contracture is a palmar fascia thickening. Kumakapal yung palmar fascia nila dito. And usually, the affected in Dupuytren's is your fourth finger. Okay? So, trigger finger, third and fourth. Dupuytren's is the fourth finger. Okay? So, you have your swan neck and boutonniere deformity. When you talk about the swan neck deformity, DIP is flex, okay? PIP is extended, and MCP is flexed. Okay? Again, in swan neck, DIP is flexed, okay? PIP is extended, and MCP is flexed. Okay? So, isa lang tatandaan ko. There's one, DIP flexion. And then, it will change, and change. So, ibig sabihin nun, flex, extend, flex. DIP flexion, PIP extension, MCP flexion. When we talk about now boutonniere deformity or buttonhole deformity, it's the other way around. DIP now is not anymore flexed. It is extended. PIP is flexed and MCP is hyperextended. Again, just one lang. Swan neck versus boutonniere. Swan neck, DIP is flexed. Okay? So therefore, kay boutonniere, extended. The next proximal joint, the opposite. Alteration lang. Again, swan neck, DIP flexion, PIP extension, MCP flexion. Boutonniere, baliktarin lang. Other way around, DIP extension, PIP flexion, and MCP in hyperextension or in extension position. Okay? So we have your claw hand. So claw hand is an affectation of your lumbrical muscles. Okay? Claw hand, again, lumbricals. Okay? So therefore, the affected nerve will be ulnar and median. Because there are 4 lumbricals in each hand. The first and second lumbricals is innervated by your median nerve, and your third and fourth is innervated by your ulnar nerve. Okay? So we have your ape hand, you know this one, your bishop hands, and we have your syndactyly and polydactyly. Okay? Syndactyly meaning web-like, nagkabit sila, or polydactyly may extra. Okay? So we have your syndactyly and your polydactyly. And then you'll see if there's some postural deviation. Usually in writing, we use positive postural deviation, C, postural assessment. So later on, you have an entry in your postural assessment. So palpation, as I mentioned before, usually done last but documented after OI. Okay, so palpation is documented after OI. So you need to check for the skin temperature if it's normothermic or hyper or hypothermic. Muscle tone, muscle guarding. Okay, you need to note if there's a muscle tone, particularly the spasticity. We have subluxation or dislocation. Okay. If there's an edema, pitting or non-pitting. As I mentioned to you a while ago, edema is under palpation. So what's the difference between edema and swelling? Okay? When I look at the patient, you don't say that, ocular inspection, don't say that, oh, meron siyang edema. No. You will document that as swelling. Okay? But in palpation, if you try to palpate that specific swollen area, then you need to palpate that and you need to document that if there's an edema. Edema can be pitting or non-pitting. So it can pit or pwedeng non-pitting. So between the two, non-pitting edema is more worse. Why? Because what will happen, pag di siya nag-pit, ibig sabihin nun, non-pitting, the proteins are already coagulated. Okay? So you don't see a sign of pitting. Okay, so non-pitting is actually worse than the pitting edema. Okay? So pitting, medyo may fluid pa, namumove mo pa siya or nagagalaw pa siya or pag pinrest. Okay? Tenderness, you need to memorize this by heart because when you document, you need to put the grade. Like for example, when I palpate this one and the patient now withdraws, like, masakit, nag-withdraw, then you document that as grade 3, tenderness on the right shoulder. Again, grade 3, tenderness on the right shoulder. Grade 1, patient complains of pain. Grade 2, complains of pain and winces. Grade 3, winces and withdraw. And grade 4, ayaw niyang pahawak. Okay? Ginaguard talaga niya. No, wag mo hawakan, masakit. That's grade 4. Also, under your palpation, you need to check for crepitations or clicking of the joints. Crepitations can be fine, can be coarse. Okay. Tightness, you need to palpate for the tightness. Okay. Contractures, and then you also palpate for taut bands, nodules, and trigger points. Particularly if there's it's part of the cervical conditions, the myofascial pain syndrome or MPS. You need to palpate if there's some trigger points and nodules in the specific area. Okay. Next, anthropometric measurement. So we have your OI palpation, we have anthropometric measurement. You need to check the limb girth measurement, compare the muscle bulk, okay? Identify body landmarks, then measure a few cm above and below, okay? If ever there's a swelling, you can use volumetric measurement to confirm if there's a swelling, okay? But usually, the most common anthropometric measurement is done in lower extremity than upper extremity. Range of motion, this is very common and you know it by heart. So you need to check for the AROM, PROM, if it's pain-free, and the end field, okay? So we start first with AROM before PROM. Don't have to measure all. So again, we do the gross measurement and then we zero in what specific joint is affected. Movements that are painful are done last, okay? Why? Because remember, if you started with those painful one, then your result might be false positive. Okay? So, overpressure is applied with caution, particularly in the shoulder. Baka malalo mo pang ma-dislocate if ever there's affectation, particularly in elbow and wrist as well. Determine whether a painful arc exists. So, a painful arc, remember, if it's 60 to 120 degrees of shoulder, for example, abduction, and there's a pain in that range, 60 to 120, then it is an affectation of the glenohumeral. But if it's an affectation around 160 to 180 or in the last 20 degrees or 30, sometimes 30 degrees, then it's an AC joint affectation, acromioclavicular joint affectation. Again, that's a good assessment because you can differentiate, it's an affectation of the glenohumeral talaga. Pag medyo nasa dulong masakit, is an affectation of your acromioclavicular joint. Okay, watch out for some trick movements. Some, if when they elevate the shoulder, they can also shrug. Okay, nagsha-shrug sila. Pag fine-flex naman yung elbow, sometimes they extend a bit. Okay, so watch for the trick movements or substitution movement. And note, of course, for the capsular pattern. Because remember, in adhesive capsulitis, there's a specific capsule that is actually followed. Okay, particularly in adhesive capsulitis, it's actually external rotation greater than abduction, greater than internal rotation. Okay, so the limitation is in external rotation greater than abduction, greater than internal rotation. So that's your adhesive capsulitis. Functional range of motion, you can combine. Like for example, Apley scratch test. I think na-mention na sa inyo before yon. Apley scratch test is the quickest way. Again, Apley scratch test is the quickest way to check the range of motion of the shoulder. So the right hand, for example, reach at the back, and the left hand reach coming from below, and then you try to reach the hands or put that particularly in the scapula. So it's the quickest way. So Apley scratch test is the quickest way to check for the range of the motion of the shoulder. We have neck reach and back reach, a combination. MMT. So after ROM, you have your MMT in the upper extremity. The key muscles are your elbow flexors. We have your wrist extensors, okay? Elbow extensors. C8 is your finger abductors and your T1 is your finger abductors, okay? Finger flexors and finger abductors. So these are the key muscles that you need to check. If with the hand, finger problem, test the muscle for each finger, isa-isa. And note, if break test is done, then document the exact location. Okay? What else? In MMT, you can also use for the hands particularly handheld dynamometer. So you can use the dynamometer, okay? So you need to do the proper procedure in doing the handheld dynamometer. Or meron din naman yung pincher, yung iniipit for the pinch grip. Okay? You can use that as well. As I mentioned, ito sila. So, grip strength, okay? And then your pinch grip. And then you need to correlate the pain and the strength. So, if they're strong and painless, that's normal. Strong, pero nung pinrest mo, merong masakit konti, baka minor lesion on the contractile tissue. Pag weak and painless, baka neurologic. And then weak and painful, there might be most likely a fracture in that specific area. So these are the correlation of pain and strength. What's good about getting the strength also of the patient, the grip strength particularly, it will also determine, sometimes has a good correlation with falls, lalo na pag matanda. So you need to take note also of those things, that grip strength is highly correlated. So the lower the grip strength, it's highly correlated with increased incidence of falling. Sensory testing, so you're done with ROM, MMT, sensory. Okay, sensory testing, you need to take down the percent of deficit as to what senses on what on what area. Like for example, 100% or sabi natin 30% sensory deficit on light touch using cotton on right C7 dermatome. Okay? And these are the dermatomes. You need to review at least the upper extremity dermatomes. In the myotomes, you need to review, in muscle testing rather, you need to review the myotomes. And then indicate the device used during testing. So you can use the paper clip, okay? You can use your cotton, and you can use also your the PT's or the therapist thumb. Next is your reflexes. So we have your DTRs. So you have your biceps, C5, C6, triceps, brachioradialis. So basic is actually triceps and biceps. And you need to take down if it's absent, 0. 1 plus is your hyporeflexive. 2 plus is normal reflexive. Pag tatlo na, hyper. And of course, 4 will be clonus. So it means there might be a nervous system affectation here. Next, your favorite. So what I did now in the special test, I did to ease for your review, okay? What I did is to put the test in the different special test, okay? So ano yung mga under na anterior instability test. This test that I mentioned here in my notes are the most commonly used and more or less valid in assessing the shoulder condition, elbow condition, and wrist and hand condition. So for anterior instability, maybe you can use the anterior drawer test here as your confirmatory, and you can use your load and shift test as your confirmatory. To do a rule out test, you can use your posterior instability test. So we have load and shift test, you can do that, your posterior drawer test. And with some multi-directional instability, you can use your sulcus-Zine or Feageen's test. Okay? Sulcus-Zine, binababa yan. Mostly yung sulcus and Feageen are more for inferior instability of the shoulder. If you have now impingement, as mentioned, there's a nearest impingement stages. So near impingement test, Hawkins-Kennedy can be done. Okay? For labral, most commonly ginagawa dito is the Clunk test. Okay? But this one is done with precaution. Okay? For scapular instability, you can ask the patient to do wall push-up. Okay? Or your scapular retraction test. Okay? That's for your scapula. For the different tendons and muscle, you have these are the most common. And I think you need to know this one by heart. Your Speed's test and Yergason's test for bicipital tendinitis. Again, your Speed's test and Yergason is for your bicipital tendinitis. MTCAN test is for your supraspinatus tendinitis. Okay? Drop arm test is for your rotator cuff tear. So we have others that you need to take note. Your lift off sign, your spring back test, and your pectoralis major and minor test. Okay? For neurologic function, you can use your ULTT. So your upper limb tension, you have ULTT 1, 2, 3, and 4 for the upper extremity. And of course, you have your Tinels. As I mentioned to you, if there's some vascular problem as well as neurologic problem or your nerve problem, you can have your thoracic outlet syndrome. We have your Roos test, okay? Most commonly used and the most known test for thoracic outlet syndrome is your Adson's test, okay? For the elbow, you have your varus valgus strain, and then you have your test for epicondylitis. So you have your Mills and Cosen's. Your middle finger test, I think this one is already changed into a new name, your Maudsley's test. Okay, Cosen's, Mills, and your Maudsley's test. And of course, if you have medial epicondylitis, you will have medial epicondylitis test. For your Cosen's rather, and your Mills, so Cosen's is a special test for the elbow, wherein is an active test, while your Mills is more passive. Again, Cosen's is active, Mills is passive. For some neurologic tests, you may want to check for your pronator teres syndrome. If you have a pronator teres syndrome, I want you to take note that in pronator teres syndrome, the pronator teres is not affected. Again, the pronated teres muscle is not affected. We have your Wattenberg test, elbow flexion test, grip test, and your Tinel sign. These are for peripheral nerve affectation. And you will have another session for this one. Meron din tayong separate for PNI. For the wrist and hand, you have to check for the capsule, ligament, and the joint instability. So there's a ligamentous test, so you just do this one, okay? But take note of the stabilization as well. So you need to review McGee for this one. Some tests for retinacular collateral ligaments like your Luno, triquetral, or Ballotman test, the Murphy sign, Watson's test, and your piano case. So these are, I think, nagpa-pop up sa inyo kung para saan siya. So take note in this while you're writing and while you're reviewing, take note what specific condition is associated with this kind of test. So we have your tendons and muscle, your fecal signs test. Okay? Paano ginagawa yung fecal signs test? Diba? Yung nakaganito. Okay? And this one is for your Decker vein syndrome. Okay? Again, Finkelstein's test is for your Decker vein. We have your sweater finger, Bunnell-Littler sign. Okay? If there's some circulation problem, we have Allen's test, hand volume test, digital blood flow, but usually they are not really done in physical therapy. So these are just for completion of the different objective examination. Test for neurologic dysfunction, you might check for Tinel's again, Phelan's test, Prayer's test, Fromen's sign, and Weber 2 points discrimination. So you can also do the 2-point discrimination under the sensory. Okay. And then, of course, your favorite, your postural assessment. So shoulder, we have the anterior and posterior and lateral views. Take note of the position, if it's in standing, if it's in supine position. Okay? And then for the functional test, these are some functional assessment. The most important here is you need to simulate the activity. Like, for example, the patient has problem with lateral epicondylitis. And then the patient is in the hospital, not in the hospital, but maybe in the hotel. So parang pwedeng bellboy, okay? And then of course, ang task nila is to grip and get the luggage, di ba? So get the luggage. So ano ba yung kailangan nilang assistance? Meron bang assistance? Meron bang nakakabit ng mga na parang protective equipment while they're doing that? What is the degree of difficulty? Okay? For example, in home environment. Meron bang difficulty? For example, a patient with rheumatoid arthritis of the hand, meron ba siyang difficulty in using the utensils or yung mga cutlery? Okay? Job simulation, for example, typing. Typing ang job niya, nasa BPO. And then, typing, and then magkaroon siya ng carpal tunnel syndrome. Okay? And of course, recreational activities and sports activities. You may want to simulate there. Paano siya nagpapalo ng nag-spike, for example, serving sa volleyball. Okay, you can do that. Paano siya mag-backhand, mag-forehand ng pag tumitira siya, for example, for tennis or badminton. Okay? But the most important is the use of the standardized outcome measure. So we have the Glasgow Pain Questionnaire. So outcome measures are very important so that your examination be objective. All right. So the last task that you need to do is you download now the uploaded outline of my lecture, and then your task is to rewrite and organize the writing activity found at the end of my lecture. All right. So we'll have some discussion after your quiz the following week or during our during our Clean Ed time this coming Wednesday. Okay, so you have your quiz in documentation, and then after that, you have some discussion. We'll discuss again, the upper extremity, and there are 3 hour synchronous session, and then we'll have a quiz the following week. All right? Thank you for listening and hope you have a good day. Thank you.